As you can see, the book can be examined as a book or by accessing the cases directly, and the cases can be sorted by number or by category. In this case, we'll pick case number 8 as an example, and we'll review the history by clicking on this link, which indicates that the patient is a 56-year-old male with recent myocardial infarction, and the study is requested to evaluate for viability. Review of the short axis images demonstrates that there is impaired wall motion of the anteroseptum, anterior wall, and anterolateral walls at the basal level, extending to involve the midventricular level and continuing to the apex. In fact, as one proceeds to the apex, it appears that there's actually anterior wall dyskinesia. This can be confirmed on review of short axis images. As one reaches the apex, one can see that there is progressively increased akinesia now involving much of the entire septum. Review of the long axis images confirms these abnormalities and demonstrates on this 3-chamber view marked akinesia of the anteroseptum. This is confirmed on the 4-chamber view, and the 2-chamber view in fact demonstrates anteroapical dyskinesia. Perfusion images are seen in the 3rd row and are obtained at rest and confirm abnormal perfusion of the anterior wall, which can be due to either inducible ischemia in the instance of a stress perfusion study, but when seen at rest indicates resting microcirculatory disturbance or resting ischemia. The next row of images are images where the normal myocardium has been made to appear black. This is done after contrast enhancement, where an inversion pulse is given and delay is instituted such that normal myocardium is nulled or goes without signal. The anterior wall infarction is well demonstrated as an area of high signal intensity on these delayed enhancement imaging, and very faint abnormal residual dark signal is noted within the area of infarction. Although at first one might think this represents viable myocardium as is seen here, more detailed analysis of this region indicates that this area of abnormal dark signal is actually completely contained within the area of prior infarction. This is confirmed on the next image as well, where a large dark region is seen within a central area, as a central area within an area of prior infarction. This therefore represents the MR delayed enhancement equivalent of a no reflow zone. This finding indicates that not only have the myocytes undergone necrosis, but indeed the small microvessels leading into the area of infarction have also undergone necrosis. This diagnosis is confirmed on review of the diagnosis within the discussion, and references are given regarding the no reflow zone and the use of myocardial delayed enhancement for myocardial viability analysis. The myocardial no reflow zone demonstrated on delayed enhancement imaging is noted to be associated with increased risk of adverse remodeling as well as other major adverse cardiac events.